Good morning. I'm Dr. Craig Egan with the Department of Pediatric Surgery. Thank you for joining us for Surgical Grand Rounds. Our speaker today is Dr. Ben Padilla, who's joining us. He attended medical school at the University of San Francisco, did internship at the University of California, Davis, residency back at the University of San Francisco, and then pediatric surgery fellowship at Children's Hospital of Philadelphia. Dr. Padilla specializes in pediatric surgery and thoracic surgery. His clinical interests include pediatric surgical oncology, pediatric endocrine surgery, and the correction of chest wall malformations. Dr. Padilla's research interests focus on the use of novel technologies in pediatric surgical disease and the surgical management of rare pediatric endocrine conditions. His research efforts have been funded by the NIH and the FDA. Dr. Padilla is certified by the American Board of Surgery and, in pediatric surgery and in general surgery. I'll remind everyone who's with us today for the CME credit, if you could text the attendance code 591237 to the number 866-327-3062. Dr. Padilla, thank you.
Okay. Please don't report us to the CDC. There's all of 8 people in the room with me, but it's a big room. So I appreciate them being here, so I don't feel like I'm just talking to myself, but it's a pleasure to be here. As Dr. Egan said, I just recently relocated here from San Francisco. I was on faculty at UCSF for nearly 7 years, and it's a pleasure to be here in Phoenix. So the topic I'd like to discuss today is congenital hyperinsulinism, and really give you the perspective of a surgeon and what the surgeon's role is in treating this disease. Admittedly, this is a rather rare and perhaps even esoteric medical condition, but I do think that it would serve as a refresher for general physiology of the pancreas and the sorts of things that we as surgeons can bring to the table. So some of the major points are that blood sugars of less than 70 in a neonate are rare and in fact dangerous. So the goal is to maintain those blood sugars above that to prevent the child from developing seizures or indeed developing more severe brain injury. Hyperinsulinism is the most common cause of hypoglycemia in the infant and in childhood. But again, it's actually a rare disease, and I would say that there's probably on the order of about 50 to 100 cases in the entire United States per year. One of the key things to remember throughout this discussion is that what we're looking at is the action of excess insulin on the entire body, and that oftentimes it may not be possible to detect elevated levels of insulin, like you might see in an adult with an insulinoma. That's not necessary for making the diagnosis of this disease. And I think the last thing, and perhaps the most important thing, what I learned the hard way, is that the management of this disease really requires a multidisciplinary team. And it's not just a surgeon and endocrinologist that have an interest in this. It's being able to enlist the neonatologist, the dietitians in the hospital, the radiologists, the pathologists. Really requires a huge group effort in getting everybody to row in the same direction. So for me, in particular, setting up this program while I was at UCSF was a very educational experience. So as I said, hypoglycemia in a neonate is defined as blood glucose less than 50 milligrams per deciliter, and the diagnosis is really quite broad. What I'd like to draw your attention to is that probably the most common thing that pediatricians would be familiar with, and certainly the neonatologists, would be this transient neonatal hypoglycemia. Oftentimes this is a result of maternal gestational diabetes. So the mother is insensitive to insulin. There's a lot of circulating insulin in the mother's bloodstream, and some of that gets transferred to the baby. So at the time of birth, the baby too is subject to excess insulin. Really the management of that is just giving them extra glucose, and with time the effects of the insulin will wear off. There's a long list of things here that I do not pretend to be an expert in. But where I do have experience is in this treatment of congenital hyperinsulinism, and particularly this top category here, this potassium ATPase sensitive channel, because this is really where the surgeon comes into play. So just to review, in the fed state, after we eat and ingest glucose, that stimulates the pancreas to secrete insulin. That insulin is secreted into the portal vein and has immediate effects on the liver, but also has effects systemically. So during the fed state, there's an excess amount of glucose that can be used for normal metabolism, but it's also deposited in the muscle, in the liver, in the form of glycogen, and can indeed be turned into fat. But in this fed state, glucose is a preferred source of energy for the brain and the muscle. In the fasting state, normally insulin gets turned off altogether, and a counter-regulatory hormone of glucagon is secreted into the portal vein. That really is kind of the brakes on the system. It does everything opposite that the insulin does. But one of the most important things that it does is it allows the liver to mobilize glycogen and turn it into glucose, and therefore provide glucose to the brain during the fasting state. It also allows for mobilization of fat to form ketone bodies and beta-hydroxybutyrate, alternative forms of fuel in the prolonged fasting state. So as I said, normally in the fasting state, the insulin levels are really quite low and the glucagon levels are high. Those high levels of glucagon allow for ketogenesis, lipolysis, as well as glycogenolysis and gluconeogenesis. So in a baby, as they are fasting, you can see that their blood glucose levels drop, and with that, you get a corresponding increase in all of these other alternative substrates. What happens, though, when there's excess insulin in the fasting state is that the insulin actually acts to inhibit the effects of glucagon. So it took me a while to recognize this, but it's not just that the glucose is being consumed quickly that causes the hypoglycemia, but what's really actually very dangerous is that the baby can't enter the normal fasting state. So glycogen can't be mobilized out of the liver to form glucose. And in the prolonged fasting state, neither protein nor adipose can be broken down to form ketone bodies, the other alternative fuel for the brain. So it's really not just that the glucose is being driven into the cells, but it's actually prevention of the normal fasting state that is really quite dangerous for the babies. So what we see here in congenital hyperinsulinism, the free fatty acids, lactate, and beta-hydroxybutyrate are actually never formed in the fasting state. And indeed, that's very dangerous for the baby. So insulin inhibits all of these different pathways. So to make the diagnosis of hyperinsulinism, what we see is that oftentimes the plasma insulin levels are really quite high. So in order to make the diagnosis of hyperinsulinism, say in a patient with an insulinoma, which is far more commonly seen in adults, what we actually see is that there's elevated levels of circulating insulin. That's not always the case here in babies with congenital hyperinsulinism. Part of that is because the release of insulin is really periodic, so they can go through these surges of high levels of insulin and then drops. The insulin is also rapidly cleared by the liver and is also just degraded while it's circulating in the plasma. So really what we depend on is, the first thing is seeing low levels of dextrose, low levels of glucose. But high levels of insulin aren't necessary in order to make this diagnosis. What we really want to see is we want to see the evidence of excess insulin in action. So the first thing would be hypoglycemia. The second thing would be suppression of plasma beta-hydroxybutyrate and free fatty acids. And then lastly is an inappropriate glycemic response to glucagon. So normally what happens in the fasting state is that as glucagon is being secreted, you're breaking down glycogen. And if you're in a fasting state, you have low levels of dextrose or glucose in your bloodstream, it would suggest that you've actually depleted your glycogen stores. And so in somebody who is just, say, fasting that had a normal insulin response, eventually they'd break down their glucagon stores, and even if you, glycogen stores, and even if you gave them more glucagon, they've already depleted all of their glycogen stores in their liver, so they're not able to mobilize more of that glycogen out of their liver. In a baby with congenital hyperinsulinism, though, that's not the case. They have low circulating levels of glucose, but they have an excess of glycogen in their liver. They're just never able to mobilize it. However, if you give them a large slug of glycogen, you can actually overcome the inhibitory effects of insulin. So what you see is this paradoxical or inappropriate increase in circulating glucose when you give the babies glucagon. So this is a protocol that we came up with at UCSF. It very much kind of mirrors what I learned during my time in Philadelphia. But we wound up doing a diagnostic fast, which can actually be really pretty dangerous because you're actually forcing the baby to become hypoglycemic. So it's important to do this in a carefully monitored setting. But we fast the babies. We check their blood sugar every 3 hours until it gets below 70. And at that point, we check it every hour. Once their blood sugar actually gets low, then we've demonstrated that they have hypoglycemia. The second thing that we want to then check is once they're hypoglycemic, we want to check for serum beta-hydroxybutyrate. If they do have hyperinsulinism, that should be low. In a baby that doesn't have hyperinsulinism, they should be able to make beta-hydroxybutyrate in ketone bodies. Once we've demonstrated that both are hypoglycemic and that they're not making ketones or beta-hydroxybutyrate, at that point, that's when we actually test them for with the glucagon stimulation test. So you give them a dose of glucagon. In a baby with normal physiology, in the fasting state, they should have depleted all their glycogen stores. In these babies, though, we wind up seeing a paradoxical increase in their circulating glucose. So those are the three things that we want to see to secure this diagnosis: hypoglycemia, failure to make beta-hydroxybutyrate in ketone bodies, and then lastly, a paradoxical response to glucagon. Okay. So the next move then that the neonatologist will do in the NICU is to manage them medically. You want to give them more sugar, so you give them, put a big IV in or get a Broviac in so you can deliver high concentrations of dextrose centrally. Now normally we deliver D5 or D10 concentrations of dextrose in a baby. The problem is that these kids will need so much sugar that if we were to give it at that concentration, they would just get fluid overloaded. So GIR is this thing called the glucose infusion rate. It's just a way of trying to quantify how much dextrose a baby's given. The normal physiologic needs in the early period of life is a GIR of about 8. Oftentimes what we wind up seeing in kids with congenital hyperinsulinism is GIRs of 20 or 30, which are actually really high. So to manage them initially, you just give them extra dextrose, get a chest X-ray and make sure you're not fluid overloading them. And like I said, get a central line. If a baby really is hypoglycemic, we can utilize this paradoxical response to glucagon to our advantage. If a baby's hypoglycemic, we can give them a dose of glucagon, just a sub-Q injection. And what you'll wind up seeing is their blood sugar come up. Now, it took a while for me to also recognize that this can actually be really used to our advantage. If you just leave a baby on high doses of dextrose, they get huge. The kids wind up getting these gigantic livers, fatty liver that's way down below their belly button. They wind up getting all this excess body weight, and it's actually it's really bad for their nutrition overall. So if you give an infusion of glucagon, what you can actually do is you can force the baby into more of a normal fasting state. And you can actually force them to mobilize those glycogen stores out of their liver. This is just a weight base. It doesn't matter if you're my size or you're a little 2-week-old baby. It's 1 milligram over a 24-hour period. It's just infused in D5 water. And with that, I've seen kids go from a GIR of 30 down to a GIR of, say, 12 or so, which makes it much more manageable to manage their blood sugars. This is a good review that was published by Dr. Stanley out of the Children's Hospital of Philadelphia about 4 or 5 years ago. And it's really just kind of a review over the last 75 years of the management of congenital hyperinsulinism. But the biggest changes have really been made in the last 15 years or so, where we've come to understand the genetics and molecular biology of this disease. So again, I don't claim to be an endocrinologist, nor do I claim to have a huge amount of expertise in islet cell physiology. But basically, the beta islet cells are responsible for producing insulin. And there's a number of signals that come into the cell that are responsible for releasing that. Now, the vast majority of these mechanisms, unique mechanisms, actually can be treated medically. There's 11 different gene loci that can be affected in this pathway that can cause congenital hyperinsulinism. The one that I care most about, though, is mutations to the potassium ATPase channel, because those are the ones that actually require an operation. So this the potassium ATPase channel is actually formed as a tetramer. So there's the SUR is one of the proteins, and the KR6.2 is another protein. So there's two of each of those proteins, and they've sort of formed this this macromolecule on the cell surface. What happens is that there's increased levels of glucose. That potassium channel closes. When the potassium channel is closed, it results in secretion of insulin. So this channel is the target of medications like sulfonylureas. So sulfonylureas target this protein. They close that gate, and as a result, potentiate the release of insulin. That's commonly used as a first-line medication in type 2 diabetics. When the potassium channel is open with low levels of glucose, that actually shuts off the faucet, and it makes it so insulin isn't secreted. And so it's mutations to this channel that actually wind up resulting in congenital hyperinsulinism that are treated with an operation. The reason for that, I'll go back for a moment. The reason for that is that all of the mutations that are upstream of here, if you treat a patient with diazoxide, what diazoxide does is it actually opens the channel and it closes off the faucet. So mutations that are upstream of this can be treated at this target. However, when these proteins are mutated, that key no longer fits into that lock. So diazoxide can't open that lock and therefore can't shut off insulin. So that's why we're stuck with having to perform an operation in these patients. So mutations upstream of the potassium channel are all treated with diazoxide, and mutations to this channel require an operation because they're diazoxide unresponsive. Now you might say, well, aren't there other steps downstream of the potassium ATPase channel that could be targets for medical therapy? For example, there's a calcium channel here. You can treat babies with calcium channel blockers. However, the sort of amount of juice that you get for that squeeze is really pretty small. So even if you treat them with calcium channel blockers, you can only partially decrease the amount of insulin secretion. The other option would be at this very last step to treat babies with Octreotide or a somatostatin analog. And again, you get a partial response, but not sufficient to really control their blood sugars. So what you're left with is with an operation. The other problem with treating babies with Octreotide is that it can actually be really quite dangerous. And in addition to acting on that final step of insulin secretion at the islet cell, it decreases splanchnic blood flow. And in a neonate whose mesenteric vasculature is still really quite immature and tenuous, decreasing that blood flow can result in necrosis of the bowel. This is a paper that a buddy of mine out of Dr. Adzik as well as Pablo Laje, one of my buddies, presented, that when you use Octreotide either for chylothorax or chylosocieties or for congenital hyperinsulinism in a baby, you can actually really harm them with NEC. So the protocol that we established is that we wouldn't use Octreotide in any baby that was less than 6 weeks of age. So what mutation is it exactly to this protein that causes the increase in release of insulin? So leave it to the molecular biologist that the protein, SUR1, is associated with a different gene. You might think that it would be the SUR1 gene. It's not. The nomenclature is a bit confusing. So the protein SUR1 is coded for by ABCC8. The KIR6.2 is coded for by this other gene, KCNJ11. It's an autosomal recessive mutation, meaning that if you're a heterozygote, if you have one wild-type copy of this, you really shouldn't manifest the disease. So most of the parents don't have this disease. With sort of conventional genetics, what you would expect then is that only babies that wind up having mutations to both alleles or both chromosomes would manifest the disease. And that is partially true. I'd just like to, as a caveat, about 5% of babies with congenital hyperinsulinism have a slightly different mutation to this potassium ATPase protein. Here, these proteins traffic normally to the cell membrane, and it's really just a problem with the shape of the lock. The diazoxide can't unlock it. The other 5% of babies actually have a dominant mutation that has variable penetrance, but in that case, the problem with this protein isn't the problem with the shape of the lock, it's just that protein actually doesn't traffic properly to the membrane. It's a small caveat, but I say it accounts for about 5% of babies with potassium ATPase congenital hyperinsulinism. I happen to treat 2 siblings in San Francisco with this problem, and then I know that there's one patient here in Phoenix that has that problem. So he hasn't had a pancreatectomy, and he's actually just being managed medically because those patients don't tend to have such severe hyperinsulinism. So this is kind of what the kids wind up looking like by the time they come to a referral center. You can see that the kids are really huge. This might be a 4-week-old baby. And he's just been getting a huge amount of insulin. They're really chubby. Their liver is, like I said, way down below their belly button. This condition, what we typically now call congenital hyperinsulinism, was formerly known as nocidioblastosis. And as I said, it probably accounts for about 100 cases in the United States a year. They tend to be large for gestational age, so there's another set of siblings that I treated, one of which was diagnosed with congenital hyperinsulinism early on, and then during the mother's pregnancy we could see that the fetus was large for gestational age, and indeed that baby also was affected with congenital HI. Babies that are treated with diazoxide tend to have hypertrichosis. You see that they have lots of hair on their back, their thighs, as well as their face. And even once you stop the diazoxide, it really takes quite a while for this effect to wane. I should back up for just one moment. One thing that I forgot to say is that if what we wind up seeing is that a baby has hyperinsulinism, we've secured that diagnosis. The next step then in trying to figure out what type of hyperinsulinism they have is just empirically treating them with diazoxide. So you should give them some diazoxide and see if they respond. Because if they do, that suggests that one of their mutations is upstream of that potassium channel. Okay? If they're going to respond to diazoxide, they should do so within 72 hours. If they don't, that suggests that their mutation is to the potassium channel, which is actually by far the most common mutation. What made me think of that is that these kids, as is often the case, they get transferred in from a NICU elsewhere, and even though they're refractory to the diazoxide, they get left on it. And so they come and they have hair all over their bodies, and it's distressing to the parents and such. If they don't respond to diazoxide within the first 72 hours, you should just stop it, beg your pardon. What you should start, and what people often fail to start, is the glucagon. If you give them glucagon, you can hopefully mitigate some of this phenotype, protect their liver, and it's much, much safer. They have much less lability in terms of their blood glucoses. So there's 2 types of congenital hyperinsulinism that we deal with. So a mutation to the potassium ATPase channel, I said, was recessive. And so what you would expect is that if you have mutations to both alleles, all of the beta islet cells in the pancreas should be diseased. And we term that diffuse congenital hyperinsulinism. If, however, you wind up with a normal allele, typically the normal allele, the positive, comes from the mother, and we wind up seeing that there's a negative allele that comes from the father, what happens during gestation is that there's a focal loss of heterozygosity, which means that there's a small nidus somewhere in the pancreas that loses expression of the wild type allele. So there's a small nidus here that actually that has unregulated insulin secretion. So these 2 entities are phenotypically identical. They both fail to respond to diazoxide. They have low blood sugars. They fail to go into the normal fasting state. So they're indistinguishable just based on the phenotype. However, genotypically we can see that they're distinct. And as I'll show you in a minute, the histology of these 2 etiologies is actually quite different as well. So for the diffuse disease, as I said, it's either a homozygous recessive mutation. What's meant by that, by the homozygous, is that they actually have the same mutation in both alleles. And I've seen that a number of times. So what that suggests is that there's consanguinity. So they come from the same small village in Oaxaca or what have you. The reason I say Oaxaca is that there's in southern Mexico and in Guatemala, where I happen to be from, there's a higher incidence of this disease. The other thing that can happen is that you can have two different mutations to the same gene. And sometimes there's just a little bit of confusion in how these things are reported out. But the word for that, if you had mutation A and mutation B, would be a compound heterozygote. So a heterozygote would be wild type plus a mutation. A compound heterozygote means two different mutations to the gene. And either of these will manifest that disease. So what operation do you do for diffuse HI? Well, if the genetics suggest diffuse disease, you don't really need to do any further diagnostic or radiographic studies. The genetics are actually very sensitive and they're very specific for this. Typically what's done is laparotomies. You make a transverse incision on the belly, expose the pancreas, and then I take a series of biopsies from the head, body, and tail of the pancreas. And we send it to frozen section for the pathologist to analyze. And what you'll see is that in these islets, you'll see that some of the beta cells have these big, huge nuclei. So the nucleomegaly, with the nucleus being 3 times the size of normally sized adjacent nuclei, is histologically diagnostic of this disease. And what you should see is these histologic changes in all 3 specimens that you've taken from the pancreas. So before proceeding to the definitive operation for this disease, it's really important that you have an experienced histopathologist who can look at these. So you send off the biopsies, scrub out, have the pathologist show you these, because it's sort of like carpentry. You want to measure twice and cut once, so you want to be absolutely sure that this is the correct diagnosis. But I think with the genetics in hand, as well as these histologic findings, you proceed with the operation I'm about to describe. The other thing that we see here is these are the islets of Langerhans, and these are actually normal. So it's really just the beta islet cells that are affected. So what operation is performed? What you really want to do is take out almost all of the pancreas. And this operation is really a palliative operation. It's really kind of a gross tool. We're just taking a hammer to the kid and whacking out the pancreas. It doesn't really do all that much to help them establish normal pancreatic endocrine physiology. What you're trying to do, though, is just prevent them from having these dangerously low bouts of hypoglycemia. So for those of you that aren't surgeons, the operation that we do for this is really unique. This is the gallbladder. Here's the common bile duct coursing down. This drawing isn't quite right. The common bile duct actually courses behind the duodenum. And then there's a portion of the bile duct that actually courses inside of the head of the pancreas, very close to the duodenum. In addition to that, here at the head of the pancreas, the blood supply to the head of the pancreas and to the duodenum is the same. So these are called the superior and inferior pancreatico-duodenal arteries. The operation that's done is to take out essentially all of the pancreas while preserving the spleen. That's actually relatively easy to do. But what's unique about this operation is that we then skirt along this plane of resection here. We identify the common bile duct, dig it out of the head of the pancreas, and we need to preserve the common bile duct, as well as preserving these arcades that are going to the duodenum, yet cutting through the substance of the pancreas here. So the reason I say that that's so unique is that this isn't an operation that's done by adult general surgeons. So for example, if a patient were to have a pancreatic cancer here, no surgeon would say, okay, let's try and preserve the duodenum. What they do is a Whipple. The reason for that is, one, they're dealing with cancer, but two, the pancreas is really, really vascular, and it tends to bleed a lot. And if you're overly aggressive with the amount of resection that you're doing here, you can compromise these blood vessels and then make the duodenum ischemic. So had I not seen this operation done or been trained in doing this operation during my time in Philadelphia, I think I would be very reluctant to perform this type of operation. So what we wind up doing is taking out as much pancreas as we can. Dr. Adzik will sometimes say, oh, well, depending on the type of mutation that they have, they might take out 95% of the pancreas or 98%. I think that's a little bit of, I don't know that you can actually know exactly what percentage of the pancreas you remove, but they have some data based on the type of genetics that the patient has that might suggest that they have either worse or less severe hyperinsulinism. In my view, I would rather take out so much pancreas that I make the kid diabetic than to leave them with congenital hyperinsulinism. It's easier, and the endocrinologists and neonatologists have more experience treating diabetes than they have treating HI. And it's actually safer for the kid. In addition to that, I wound up leaving a gastrostomy tube. So with time, it actually evolved how I would do this operation. A friend of mine at UCSF was a neurosurgeon, and I sort of go into the operating room to see what he was doing. And he was dissecting a tumor out of the brain. And I said, the brain looks kind of like the pancreas, and I guess in some ways it is. It's a neurocrest organ. And the way they dissect through the brain parenchyma is with bipolar cautery. Dr. Adzik would usually just cut through this with regular cautery. I actually think it's way, way safer to dissect through the substance of the pancreas with bipolar cautery, because you can actually cauterize the blood vessels, you don't have as much bleeding, and then you don't have as much spread of heat. So thanks to Curtis O'Geist, that's kind of what gave me an idea for doing that. And I actually found that it was a much safer and less bloody way of doing the operation. So what you're left with is something like this. I tried to get my daughter to teach me how to do drawings on the iPad, but she was too busy playing Animal Crossing. So these are just little drawings from my files, but we wind up with the stomach here. Here's the liver and the bile duct coming down. You just have this tiny little rim of pancreas. That little rim of pancreas, though, can still secrete not just too much insulin, but more importantly, it secretes insulin at the wrong time. So it's not just a quantity sort of thing, but if you're already fasting, you haven't just ingested a bunch of glucose, what winds up happening is your liver can't actually mobilize the glycogen. So it's not just the absolute amount of insulin that's being secreted, it's when it's being secreted. So as I said, this is really a palliative operation, with about a third of these kids becoming euglycemic, a third having persistent HI, and then a third becoming diabetic. In the long term, though, these islet cells, they're working their butts off. They're producing lots of insulin. Eventually, they conk out. And if you follow these patients long enough, they eventually all become diabetic, and pretty brittle diabetics at that. So the reason I put in a G-tube then is, even if they, you might say, well, these patients that have persistent hyperinsulinism, was that operation a failure? And the answer is, I wouldn't consider it as such. Oftentimes then what you've done is you've gone from a glucose infusion rate, say of 15 or 20 or 25, and you've gotten them down to a glucose infusion rate, say of 8 or 10. And that's way more manageable. In fact, you can actually manage that by giving them dextrose into their gastrostomy tube. So with a regimen of intermittent feedings fairly close together, and then a continuous infusion of dextrose, with basically sugar water into their stomach, you can prevent them from becoming dangerously hypoglycemic. Now you might say, why don't you just do that from the outset? If you try and give a baby a GIR of 20 into their stomach, it actually has a paradoxical effect. So what you wind up doing is you wind up stimulating the islets to secrete even more insulin. So you can really only do this safely to a GIR of about 8 or 10. And then what winds up happening is you shoot yourself in the foot. You go to GIR of 10 to 12 to 20 and then part of it is that you're just overstimulating the pancreas. So you really want to get as much of that, get rid of as much of that as you can. In this group of kids that are in this 1/3 category, you can also treat them with some octreotide. So if you've actually gotten rid of the majority of this pancreas, now you can treat them with octreotide. And oftentimes what these kids will have is a cyclical secretion of their insulin. So by having these kids on continuous glucose monitors, you can actually kind of figure out when they tend to drop their insulin, and you can time when you give them the octreotide. Typically, octreotide can only be dosed once or twice a day because they develop tachyphylaxis to it. So if you can figure out when they tend to become hypoglycemic, you can time the dose of octreotide to try and abate that hyperglycemia. Not surprisingly, all these kids wind up getting exocrine insufficiency as well. So they need to have pancreatic exocrine enzyme replacement to ensure that they have adequate absorption of fat. So you might say, well, all these kids are fat already, but really you need to be careful that they're absorbing the fat-soluble vitamins as well as proteins. So having a dietitian help you with the management of these kids is hugely important because the kids are already obese, but you want to prevent them from getting malnourished with respect to micronutrients and as well as proteins. So I got about 20 more minutes. So for focal disease, as I said, we think that it's a two-hit theory where you get a paternally derived mutation of one of these two genes. Again, I'm not a geneticist, so I don't completely understand why it's always from the father. But what you wind up getting is a wild-type allele from the mother, a mutant gene from the father, and then you wind up having loss of expression of the paternal mutation. So if you are going to do genetic testing for these kids for congenital HI, it's important not just to test the child, but you should also test both parents. And particularly, you should test the father. Because what can happen is that if you wind up having the same mutation in both the parents, it can be very difficult to determine if they have this disease or if they have diffuse disease. So checking both the child's genetics as well as the parent's genetics are important. Okay. So what operation do we do for this? So until about 15 years ago, the operation that was done is you'd have a look at the pancreas and see if you can actually find this little focus of disease. The truth is, if you have a focal HI lesion, it does look subtly different from the surrounding pancreas. It has a slightly different color. It has a little bit of a purplish hue. But sometimes these lesions are really quite small, maybe a 2 or 3 millimeter lesion, and it can be hard to see. So if it's on the surface of the pancreas, that's great, but if it's behind the pancreas or inside the substance of the pancreas, you can't see it from the surface. So the operation that was done about 15 years ago is that they just do a distal pancreatectomy, and hopefully the portion of the pancreas that you resected contained the lesion. If they had persistent HI, then you go in and start taking more and more of the pancreas and having the pathologist look at the slides in the operating room to see if you actually got into some diseased tissue. The result is that you could wind up taking out essentially all of the pancreas for a disease that could have been cured by just removing a small focus. Okay. So about 15 years ago came this technology of this 18F-DOPA. So dopamine is a precursor for norepinephrine. And so the islet cells in the pancreas are neuroendocrine cells. They actually take up dopamine. So if you can label dopamine with this 18-fluoro compound, it'll actually light up on a PET scan. So in a normal individual, if I were to get an 18F-DOPA scan, what we should see is that there's 18F-DOPA being taken up uniformly throughout the pancreas. The problem is that nobody's really interested in making this stuff. It's not going to make a lot of money for anybody. Okay? It's not FDA approved, and there's no entity that's interested in making it FDA approved, sort of pushing it through. So in order to use this compound, you have to have what's called an IND. It's an investigational new drug protocol from the FDA. So that's one obstacle. The other thing is it's not commercially available. So you have to be able to make the compound yourself. So there's large medical centers around the country that have the capacity to do that. Among those is at CHOP, and then during my time at UCSF, we did secure an IND and had the ability to make this compound. To my knowledge, these are the 4 places around the United States that have the ability to make 18F-DOPA and have INDs for this. The reason I say that nobody's really going to make any money off of this, and and because it's such a narrow market for this. The other thing is that many of these centers view it as a sort of a bar that you got to clear in order to get into the business of treating congenital hyperinsulinism. So most of these places are very reluctant to do the diagnostic study and then send the patient back to you. If you can do the diagnostic study, then you sort of have a captive audience. So it's a tool that if it suggests a focal disease, the next step in the diagnosis of this, not in the diagnosis, but trying to localize this disease, is doing an 18F DOPA scan. It's actually the sensitivity and specificity of this test is really quite good. So this is a patient with diffuse HI. This was a study that Dr. Adzik did looking at the utility of 18F DOPA, and they did this scan on all patients, whether they had diffuse or focal disease. But really the genetics are so good, I don't think Dr. Adzik any longer does 18F DOPA scans for diffuse disease. What you wind up seeing is uniform uptake of the 18F DOPA throughout the pancreas. So here's the head of the pancreas, here's the body and tail of the pancreas. But this looks like a normal pancreas to me. As I said, if I were to get an 18F DOPA scan, I would hope it would look something like this. However, if a patient has a focal lesion, that focus has an increased avidity for the dopamine because there's hyperplasia of the islets in that area. So what you wind up seeing is a bright uptake of the 18F DOPA here, and then the rest of the pancreas actually looks relatively attenuated compared to that area of focal disease. So here's a patient that, this is actually the first patient that I did an 18F DOPA scan at UCSF, sort of fingers crossed, biting your fingernails to see if the thing is actually going to work. It's pretty cool. We made the compound, gave it to the kid, and scanned him. And what we can see is that here's the pancreas. And the pancreas is normally taking up the 18F DOPA, but then there's this bright spot. Now here on the CT scan, you can actually see that tiny little nodule, but more often than not, you can't see anything on a CT scan, nor an MRI. So it's not usually recommended to just get those without the benefit of a DOPA scan. So this patient, we could actually mobilize the pancreas, remove this tiny little focus, and the kid was cured. And I'd say that we probably took less than 2% of the child's pancreas. So this operation is very satisfying. The other is a sort of blunt instrument where you're just trying to get the kid by. Here, with a very precise and targeted operation, you can cure them of the disease. So one operation for focal disease is a focal resection. This is another child. It's a slightly different projection. It's not superimposed on the CT scan. Here are the kidneys, here's the ureters. The 18F DOPA is cleared in the urine. But you can see that there's uptake of the 18F DOPA in the body and tail of the pancreas as well as the head. And then right here, what we kind of term the neck, right where the mesenteric blood vessels are, we see that there's this area of huge uptake. Now, unfortunately, I don't have a picture from the operating room on this child, but when I operated on him, I couldn't find the lesion. But I knew based on the CT scan that it was to the left of those vessels. So what I did is I took all of this portion of the pancreas. In general, we say that the body and tail of the pancreas is about 50% of the islet cell mass. So even with resecting 50% of this child's pancreas, they still have sufficient endocrine and exocrine function, and this child was cured with a resection of about 50% of the pancreas. So I would call that a segmental resection of the pancreas. And typically this is a pretty straightforward and easy operation, doing a distal pancreatectomy. More difficult operation, though, is what if they have a focal lesion here in the head of the pancreas. So in this kid, you can actually see this lesion pretty clearly, and I resected it, and I thought I was done. But that wasn't the case. What happens is that unlike insulinomas, an insulinoma has a capsule, and it's just this area of hyperplasia. Focal congenital hyperinsulinism lesions aren't encapsulated, and they tend to have these roots or tentacles that can extend deep into the pancreas. So when I resected this, I sent it off to the pathologist and had them look at the resection margin, and they could see that there was still disease there. I resected deeper into the pancreas still, and there was still disease. So ultimately what I wound up doing was a pancreatic head resection. Again, not an operation that's done by the adult general surgeons. I transected the pancreas at about the midpoint, what we call the neck of the pancreas, and I resected the entire head, preserving the blood supply to the duodenum as well as the bile duct. People used to think that this operation would fail, but Dr. Adzik demonstrated that it actually works pretty well. In an adult, when you reconstruct the pancreas, typically you sew the intestine right to the bile duct, or pancreatic duct. In the kid, the pancreatic duct is too small to see. It's actually not that hard to do, but if you just stuff the whole pancreas into the end of the bowel, the pancreatic enzymes will drain and the kid actually does fine. So it preserves both endocrine and exocrine function. So again, this is a segmental resection, but a more complicated operation. So it's a resection of the head of the pancreas, preservation of the body and tail with a Roux-en-Y pancreaticojejunostomy. So the goal of operations for kids with focal congenital hyperinsulinism is to preserve as much of the pancreas as possible to preserve both endocrine and exocrine function. So what's the histology of focal HI and how is it different? So here's a lesion, a focal lesion, and we've sectioned this. When it's stained with chromogranin, we can see that it stains really avidly. So this is normal surrounding pancreas. Some of these so chromogranin is a stain for cells of neurocrest origin, so skin, melanoma, brain tumors. They'll all stain positively for chromogranin. So this is normal pancreas here in the periphery, and we see that it does stain positively for chromogranin because they do have normal islets. But you can see that there's this area of hyperplasia, the dense uptake of chromogranin. The other thing that we see that's unique is that here we wind up seeing hyperplasia of the islet cells. Now for insulinomas, the only thing that you see on an insulinoma, in addition to being encapsulated, is that the only endocrine elements that are hyperplastic in an insulinoma are the beta cells. They don't have hyperplasia of the alpha cells, nor do you wind up seeing exocrine components within the lesion. It's all endocrine components. In a kid that has focal HI, in addition to seeing hyperplasia of the beta cells, which you can see here, so this is hyperplastic, this is what a normal islet would look like, and you can see that these islets are all crowded out. So that's the hyperplasia of the islet cells. But these are the epithelia, see how they're lined up here? So this is the exocrine component of the pancreas, and then these are the pancreatic ducts. So we wind up seeing exocrine components within the lesion as well. So that's one of the ways that these are histologically different than insulinomas. So, when we resect this, what we want to really be looking at is we want to ink the margin and make sure we don't see extension of this and these sort of fronds extending into the pancreas to make sure that we have a clear resection. So, I said I was in UCSF for about 6.5 years. It took a while just to get my feet under me as a newly minted pediatric surgeon, and it took us almost 2.5 years to get the investigational new drug protocol up and running. But I guess in the last 3 years that I was there, I treated about 16 kids with some form or another of hyperinsulinism. 8 of these kids had diffuse HI. We did a near total pancreatectomy on all of these. One of those kids needed a reoperation. One was palliative, 4 were diabetic, and 3 had persistent disease. Okay, I'm sorry, and 3 were cured. For the kids with focal HI, among these lesions, 2 of them actually wound up having a pancreatic head resection that I described. One had a distal pancreatectomy, and the other 3 were just focal lesions that I was able to pick off. Well, I won't get into this. I also, during my time there, treated two kids with insulinomas. One was a teenager who was having bouts of hypoglycemia that were really quite dangerous at night. He had seizures and was worked up for a brain tumor. And then the other was a child with MEN1. She was really the index case, and then when we went back, we diagnosed both her mother and her aunts with the disease as well. And both of those patients were cured. So, my results at UCSF were really kind of in keeping with what's been published at the large institutions. So the big places would be Great Ormond Street in London. I forget what the hospital's name is in France, and then at Children's Hospital Philadelphia. But about 50% of them still have some persistent HI, and they're palliated. About a quarter become diabetic, and a quarter are cured. As I said, I was actually pretty aggressive with treating this because I'd rather manage a diabetic than manage somebody with persistent HI. You can treat with Octreotide for those kids that are palated, that have diffuse disease. I think I talked a little bit about the management with a continuous dextrose infusion into the gastrostomy tube. I think really the thing to remember is that the dextrose that you're giving into the stomach is a medication. It's not a substitute for food. So when you're managing these patients' nutrition afterwards, you should really view the dextrose infusion as a medication to prevent the hypoinsulinism, and then manage their nutrition separate from that. So really what I learned is it takes a huge team, and you got to get everybody rowing in the same direction and have people that are interested in treating this disease. It's not just about a surgeon or an endocrinologist, as I said. You know, I think there's the future of this is perhaps either once you perform a pancreatectomy, isolating the islets and perhaps genetically modifying those, transfusing those back into the patient so that hopefully they're physiologically more regulated. But there's also a couple companies out there that are working on medical treatments for diffuse congenital hyperinsulinism. I think I'm out of time, and I think probably other people are out of gas too, but I hope that was interesting and educational. You guys have questions?
Thank you, Dr. Padilla. As a pediatric endocrinologist, I'm especially impressed by your understanding of the subject. We do have a few minutes for questions, and if you're watching this online, to use the chat function. Dr. Padilla, can you give a sense of the experience here at PCH in the short time you've been here? How often we're seeing this condition? I know it's very rare.
You know, I've only seen the one child here that had this really what amounts to a very rare mutation, which is the dominant form. And I think that child had actually been referred to Cook Children's Hospital in Dallas, and they appropriately chose not to operate on that kid because his hypoglycemia was relatively well managed medically. Aside from that, my understanding is that most of these patients have been referred elsewhere. Is that right, Dr. Natrika, Dr. Egan?
When I first got to Phoenix, we were routinely doing operations on these kids. We'd ultrasound them, and if we didn't see a focal lesion, then we would do a 95-98% pancreatectomy. And then for a brief period of time, when CHOP was offering the genetic test, we were sending them to CHOP. When the genetic test didn't pan out to be the end-all to be-all to identify who should and should not have, or who had diffuse and who had focal disease, we went back to doing them. And then I think since that time, Craig's done two of them, and I think, yeah. So we're doing a few, but again, we have the same limitations, which is that you know, getting an IND for the 18 fluorodopamine is difficult. And so at this point, we're kind of, I think, referring most of them out.
I think, in speaking to the endocrinologist here, I think that if a child had disease that was suggestive of diffuse disease, I would be willing to treat that child here. I feel pretty comfortable doing biopsies, looking at the slides with the pathologist, and if we corroborate the diagnosis, then doing a near total pancreatectomy. I do think, though, that if the genetics are suggestive of focal disease, you're exposing yourself to liability, not getting a preoperative 18F-DOPA scan. The 18F-DOPA isn't to be confused with the dotatate scan. Dotatate targets neuroendocrine tumors as well, like insulinomas, and really the target of that is a somatostatin receptor. So dotatate is actually very, very sensitive and very specific for insulinomas. They've tried to use dotatate for the localization of focal HI lesions in Europe, and it just didn't work. But so dotatate shouldn't be mistaken for, and dotatate is FDA approved, and you can get that scan everywhere. You can just buy the stuff, and there's actually two forms of dotatate. There's the diagnostic form, and then you can actually, it's radioactively labeled, so you can actually do ablation. So patients with insulinomas that are metastatic to their liver, one of the ways that you can palliate them is with treating them with radioactive dotatate. My guess is they probably do that up at the Mayo Clinic. Yep.
If you can get an IND, how long do you have from the time that the fluorodopamine is made to the time you have to infuse it?
Yeah. Not long. Probably you probably have 12 hours.
For the patients who have diffuse and the operation's successful, then what would you say is the average amount of time or the average age at which they then become diabetic?
I think a little bit of depends on the extent of the operation, but for example, the child that I treated who was large for gestational age and had an older sister who also had the disease, she required a dextrose infusion as a baby. By the time her younger brother was born, she was 4 years old. She was euglycemic, but typically by the time they get to be teenagers, most of those folks are diabetic. And some places, my guess is at the Mayo Clinic at UCSF, I did see a couple patients getting pancreatic transplants for that, or islet cell transplants, but part of it is because their diabetes it can be also difficult to manage. They can be really pretty brittle diabetics by the time they get into adulthood.
Have you seen any of these kids with any other major congenital abnormality that will prevent or complicate the treatment of this?
Yeah, so that's a good question, Juan. I think that maybe what you're getting at is Beckwith-Wiedemann. So the kids, about 50% of kids with Beckwith-Wiedemann have some element of hyperinsulinism. It's usually not due to a mutation to that potassium channel. There's some small reports out of CHOP and out of Europe for doing partial pancreatectomies for kids with Beckwith-Wiedemann and really difficult control congenital hyperinsulinism. The vast majority of those kids are responsive to diazoxide and can be managed medically. I would say that the kids that have the autosomal dominant form of the potassium channel mutation, those kids aren't right. I treated a family back in San Francisco, a little boy and then his older sister who had that mutation. And it actually affected their entire hypothalamic pituitary axis. They both had hyperpituitarism, their thyroid didn't work. So that potassium channel isn't just expressed in the islet cells, it's actually expressed throughout the body. It turns out that it's most important for insulin secretion. But I think its effects in other endocrine organs are incompletely understood. And so those kids that have a failure of that potassium channel traffic to the plasma membrane, they also have other problems in addition to the hyperinsulinism.
Great discussion. Thank you so much, Dr. Padilla.
Yep, thanks guys.